Dr. Ramamurthy. Now I invite Professor Mahipal Sachdev, who is going to talk about hard cataracts, the different difficulties we face, and how we manage these cases. Because country like ours, I think more than 40 to 50% of cases will have hard cataracts, and we all have difficulties doing the effective phaco in these cases, which doesn't harm the the ocular tissues. Dr. Mahipal, sir.
Thank you very much, Dr. Professor Tityal. I think it's always a pleasure being in your course, and I think Professor Tityal is one of the finest surgeons I've ever met. I'll be talking about hard nuclei and the different grades and how you manage it. Now, when you're looking at a hard cataract, it always is a challenge. And why do we say that it is always a challenge? Because there are, all of us know, and there are several studies which have been done, which shows that when you're dealing with brunescent cataracts, white cataract, intumescent cataracts, hard cataracts, they are almost always associated with an increased possibility of having complications. So that is the reason why we need to understand as to what it is. Now, when you're looking at a hard cataract, it should not come to you as a surprise on the table. That is the most important thing, that pre-operatively you should have considered that this is a hard cataract and as to what one needs to look. So the first thing that you need to look in these cases is to look at the pupillary dilatation. If a patient in the OPD is not getting dilated, say within 30 minutes or 45 minutes, and the pupil is small and the patient is a male, always ask the history of BPH. And when you ask the history of BPH, you need to ask whether the patient is taking tamsulosin or not, because today it is being used left, right and center by the nephrologist or the urologist, and that causes us reasonably severe problems during the surgery. So we always write patient on tamsulosin. It is always better to use some retractors, etc., and maybe start the patient on atropine. Stopping tamsulosin does not make any difference at all, because whatever has happened to the tone of the pupil, it is not going to reverse. Now, the next thing that you need to understand in a hard cataract is to look that you are going to cause more collateral damage to the corneal endothelium, because you are working on a harder cataract and you are going to use more energy. More the energy you use, more would be the damage on the corneal endothelium. The next thing is that whenever you are seeing either an intumescent cataract or a hard brown cataract, you need to look at the zonular integrity, because the zonular integrity obviously gets compromised in cataracts which have been sitting there for a longer time. Morphology of the cataract is obviously important, and normally the patients nowadays are smarter, or I don't know, stupid, I would say, that they don't often tell you if they have pre-existing posterior segment diseases or not, and that is why they have not got the cataract surgery done, because the doctor might have told him earlier that you have a scarred ARMD, this, that and the other. So what you have to do is that whenever you see a cataract that has been sitting into the eye for a long time, be very careful that an assessment of the posterior segment is something which is very, very important for you to actually prognosticate the patient. Now, why is hard cataract a challenge? The first thing is that there is a reduction or an absence of the red reflex which is there. There could be milky fluid, so this compromises the visibility and you don't get a red reflex, which is obviously something very, very important when you're doing a phacoemulsification. Harder the cataract, more the chances of fibrosis of the nucleus, and therefore capsular changes and poor visibility cause difficulty in doing a CCC. Now, hard cataracts, because they have been sitting for a longer time and they tend to be swelling up, therefore the space for surgical manipulations also reduces and you are nearer to the corneal endothelium while you are doing a phacoemulsification. Also, corticocapsular adhesions cause difficult hydrodissection, difficult rotation, but I would say that this is the most important thing that you have to look at in the nuclear changes, is that the hard brown black cataract has leathery interdigitations which are there at the bottom of the nucleus, which is like what we call the spine of the lens. And till we break that, that is the biggest problem, that we do not break that, we are not going to get a good outcome, and the whole thing tends to come out and you have problems that is there. Now let us see that how does one target the nucleus. Now if you look at the anatomy of the nucleus, what you have to understand is that the center of the nucleus is the thickest, okay, when you are doing early, people doing phacoemulsification early, they tend to go and they tend to break this, which is in the periphery, which is easier to break, but it does not serve any purpose, because till you have broken the central core and you have separated the leathery fibers, it will still remain interdigitated and you are going to have a problem. So mind you, we have to break and target the center of the nucleus and not the periphery of the nucleus, and that is what is very, very important. When you are doing a nucleotomy, there are various ways. You can trench, you can split, or you can chop, and different surgeons have their different preferences which are there. Now, in case you are to split the nucleus, what you have to do is to use two instruments, but then you have to see that the center is broken, and you have to understand that you have to have a deep enough trench. If the trench is not deep, you will not be able to break. So if you see here, this is a superficial trench, and you are trying to break this. Both your instruments are superficial. So you can see that the vector is working like this, and it is not working the way it has to work. So what it has to work is that you have to go deeper and then try to break, and therefore this vector forces will work like this, and this will then crack the center of the nucleus. So that is something very, very important that I'll be emphasizing and re-emphasizing for you. Now, nuclear emulsification, the chopping techniques can be a divide and conquer, stop and chop, primary chop, crater divide, circumferential, whatever you want. My preferred technique for several years is a primary chop. I do not trench, I do not do anything, but go ahead and do a primary chop. Let's see chopping. Now you can see that this is a grade 5 cataract. The chopper is right in the center near the capsular axis, but you can see that the depth is there and you are separating it. Come down to a grade 4 cataract. Again, you can see this is the chopper burying in the center. You see the difference between the phaco tip and the chopper is very little. You don't need to go to the extreme periphery. If you want to do a Nagahara chop, that's something different. But you can see with different grades of nucleus, even in grade 1, this is there. But even with the hardest cataracts, you can do a straight direct chop by burying into the nucleus. Well, what is important is that you push down the nucleus slightly, so that when you are entering the nucleus, you are entering slightly above. And by the time you are burred in, that time you are in the center. So the deepest part is where you are done the burying is in the center, and then you go ahead and disassemble the nucleus. Now, people do crater divide and chop, sculpt and chop, drill and chop. These are modifications which could allow safer emulsification. Now, in this particular case, just look at the parameters that we are going to use. The parameters vacuum is going to be pretty high. So you can see we are making a trench, okay? But you are going into the same groove. I am not widening it. You are going into the same groove, and just watch here. Just watch. The difference between the tip of the nucleus, which is almost at the center, and the chopper is very little. And that is why you are now having the movement. So I am not going to the periphery to disassemble, but I am doing a direct chop, and you can see here, just watch the fibers. Can you watch the fibers? There. Again, I can see that this is still not broken, so I am still disassembling it, and you can see that this is still attached at this particular point. So what one has to do is to rotate it, okay? And rotate, again go into the depth of the nucleus, and again go bury. Look at it. Can you see this? This is the problem till you have broken that. Once you have broken that, the segment gets disassembled, and you can go ahead and remove the nuclear fragment. Now this fragment is flying about, which can cause damage to the endothelium. Now you can see here again, look at the depth at which we are going. Look at the chopper being very near and just being at the rip of the capsular axis. Again you can see, again I'm still working, and here till we have the disassembly. There you see. This has been disassembled, and it's only once it has been disassembled that you go ahead and do that. Otherwise, the whole thing will try to come, and you are going to have a posterior capsular rent. Now, this is again a brown cataract that was on a different machine essentially. What you have to understand is that the parameters that we use are going to be based on the machine. If it's a lower end machine, please do not go ahead and use 500 vacuum as we are using in this particular case. You can see this is a signature. Again, I am trying to show you a very, very thick leathery fiber. There again, just see that direct chop is a fantastic way for you. You can do a trench and then chop, but disassemble the center of the nucleus, rotate it again, go back, hold it, and again, so you could see that's a surge because the hold was not too great. We will go back again, you can see again holding, you can see these are the parameters, and here what we are doing is we are using two instruments. So if you are not getting a chop with the phaco machine, with the phaco tip and an instrument, you can put viscoelastic, use two instruments and disassemble it. So that is what we are doing, is that we are using two instruments, rotating it. It's actually a pretty hard cataract, and then we are disassembling it and then using a phaco probe. Now let's come on to a case which I would say is a black cataract. Now, a femto laser works wonders to reduce the effective phaco time in these cases, and you can see that the ease with which we can split the nucleus is going to be much better. Now, this was a case where my associate said, sir, give it to us, we'll do an SICS, because I don't know how to do an SICS. But I said, my ego came in the way. I said, no, let's do a patient wants a femto, so let's do a femto. So the first thing is you get a great capsulotomy. When you're doing a capsulotomy in a hard cataract, make it slightly bigger. It should not be a small capsular excess because the nuclear pieces are large and they don't come out. Now what I have to show you is that there is a pre-chopping that has happened. Even though you felt you don't see too much of a cleavage, but look here. Look at this. Just watch here that this is getting, can you see these bubbles coming in? This is where the femto had worked and the bubbles and the pneumo dissection, pneumo separation had happened. And can you see the ease with which I can separate it? You could see that it was disassembled much easier. Can you see it? And this, again, there are 8 quadrants that we have done. You increase the energy on the phaco. Again, you see that we have disassembled. You see here, look at the black cataract that is there. For paucity of time, I'll just show you that despite it being black cataract, you have these slices that have happened, which have happened because of the femto having taken place, and that's the last piece that is coming. You can see that we are able to work with a good fluidic balance with a pre-chopped nucleus, and you can see that the effect would be that you can go ahead and get a good outcome post-operatively. So intra-operatively, there can be problems, difficult situations during nuclear emulsification, and I think majority of the problems happen. You have to, if you get a PCR, please note it early. And incomplete separation of nuclear fragments following chopping is the main reason for which you cannot have a separation that is there. Hard cataracts tend to be leathery and tenacious, making nuclear division difficult. So you have to break the center of the nucleus. If you do not break the center of the nucleus, either you will blow up the cornea with increased energy being used, or you will have a PCR. Absence of an epinuclear cushion for protection of posterior capsule is the other problem, because there is no epinucleus that is there. At the time when you are going in for the last piece, that is the time when your adrenaline surge goes down and then you relax, but that is the time for you to actually reduce your parameters, because there is no epinuclear cushion, so you should reduce your parameters. Viscoelastic may be injected behind the nuclear fragments to serve as a protective cushion over the posterior capsule. If there is a PCT, if there is a PCT, early detection leads to optimal management. Management depends upon the stage of surgical procedure at which PCT has happened. A dispersive OVD tamponades a PCT, enabling completion of phacoemulsification and preventing vitreous loss. An anterior vitrectomy, possibly through the posterior route, would help take care of the vitreous loss and do a vitrectomy. And in case there is a PCR, place a 3-piece lens, or if it's a larger one, go in for a glued intraocular lens. So that is all that I wanted to tell you, that phaco in hard cataract is a different ball game because of prolonged surgical time, causes increased inflammation. So post-operatively, I always use cycloplegics like atropine, which reduces the corneal edema because it reduces the prostaglandin released by the ciliary process, and you have to give topical NSAIDs to reduce the chances of CME in these particular cases. So IOP needs to be monitored post-operatively, and that is what, because you have used chondroitin sulfate, etc. So this is all that I wanted to say for managing a hard cataract. Thank you very much for your kind attention.
Thank you so much for sharing